Well, hello, everybody. Welcome to Medicine and Science on the Pod TV network. I'm Nick Pallavita. I will be your host for today's presentation. And today's presentation will be delivered by Dr. Michael Patmos, who is a real medical doctor with he's certified in internal medicine with additional qualifications in infectious diseases. And today we have a very special topic we're going to discuss. Now we're going to discuss vaccines, which we bring up almost every week in this show, but because it's an important topic and people are being misled in the area of vaccines. But we're going to bring in a special topic today, which is seizures, because some of our viewers have wanted us to discuss this very interesting area and about seizures. In other words, what is it? What does it do? How do you get it? Can you get rid of it? Can you treat it? What's going on? So with that, none other than your hero for the day, the Honorable Dr. Michael Patmos, who will give us the lowdown on seizures as soon as he gets on.
Well, I don't see myself on the. Do you see me? There we are. Oh, okay.
No, you have to have the magic cameras
I
hit
see.
it correctly. And the magic camera hits it correctly, you're on. Okay, seizures, Dr. Patmos.
Good morning, Nick, and good morning, Rick, and to all the other viewers. And yes, my name is Michael Patmos. I'm an internal medicine doctor with added training in infection control. I'm not a neurologist, and as I always say, physicians should stay, within their zone of expertise, and when they're opining as an expert. Now, with that, I will add that I do have a lot of experience. I feel I can speak to this in general terms as an internal medicine physician because I've had to treat many patients with seizures and seizure disorders and have a lot of experience as a primary care physician treating seizures. And I also did significant research when I was in medical school on the underlying molecular biology of the intracellular ion fluxes that happen before a seizure. It was my professor's. I was a student working in a lab. It was my professor's research. I just executed it, but it was the professor's idea. And I got a very nice publication and an award out of it, but I didn't claim it was my idea, as some other famous doctors do. They tend to take their medical student research and claim it as their own. In any case, I have a background in this. I did 6 months of neurology as a resident, so I could speak to this topic, but for the listener, nothing I say will substitute for the information that you would get from a neurologist, especially one who is specifically trained in seizures. That is actually its own field. It's called epileptology. So for someone who has complicated or hard to treat or issues, seeing a neurologist is very important, and even an epileptologist is recommended. So having said that, what can I tell you as an internist about seizures? Well, first of all, what is a seizure? A seizure is a transient abnormality in brain function, and it can be localized or it can be generalized. Seizures can be provoked or unprovoked. Now, what's the difference there? Well, a provoked seizure has a definitive cause, such as a blow to the head can cause you to have a seizure. A drug overdose can cause a seizure. Low oxygen level in your blood or other electrolyte abnormalities, metabolic disturbances like low sodium, hyponatremia can cause a seizure. Drug exposure, cocaine, methamphetamine, all of those can cause seizures. So you'll sometimes see in boxers, when they get knocked out, they have a momentary twitching or seizure activity. Those are provoked seizures. That is not epilepsy. And people get confused between the two. Epilepsy is an unprovoked seizure, not due to an acute insult like a drug overdose. And with epilepsy, there can be different causes. Epilepsy, if you have to have one very severe seizure, like almost a life-threatening one, or two seizures occurring at separate intervals, and then makes the diagnosis of epilepsy. Epilepsy has several causes that can often be identified. It can be the result of a tumor or a structural anomaly of the brain, like a AV malformation or some other structural lesion in the brain, or even after a stroke, or it can be due to something growing in the brain, like a tumor. Sometimes with the elderly who've never had seizures, they develop a seizure late in life, and then a year or two later, a lesion is actually identified on MRI that was really the cause of it, but wasn't seen in the very beginning. Or seizures can be due. There are genetically transmitted seizure epilepsy disorders, and then there are some that are just idiopathic that people have for no identifiable reason. Just a brief comment about the difference between febrile seizures in children and epilepsy. A lot of people can, children will sometimes, babies and little kiddos will sometimes get a seizure when they have a fever. And people freak out that means they have epilepsy. No, it doesn't mean they have epilepsy. Febrile seizures are not epilepsy. They're generally benign events, and they occur once or maybe twice, and it's related to a fever. It's one of the provoked causes of a seizure. And sometimes, even rarely, a seizure can occur after a vaccination. That does not mean that the vaccines cause epilepsy. You have to understand the difference between provoked seizures and unprovoked seizures, between a seizure and the disease of epilepsy. Two very, very different things. Now, having said that, how does a patient with a seizure what's the evaluation? Well, the evaluation includes obviously blood work. You want to check for, the electrolytes and so forth, excluding drug exposures and that sort of thing, and then imaging. But the most important thing, one of the reasons I love neurology is because there are certain things that only a neurologist can do. No one else can do the kind of proper evaluation on history and physical that a neurologist can do. A good neurologist can put any other doctor to shame and embarrass the heck out of you when it comes to doing a neuro exam. They know more abstruse and unusual physical exam findings than anyone. But the evaluation of seizures is very heavily dependent on the physical examination. Yes, we go to imaging, but the description obtained by the physician from the witness is crucial. Exactly how this seizure presented and manifested, and how it evolved. They can be, for example, they can start locally, like just in an arm, and then become generalized. They can occur in one part of the brain or another part of the brain. They can be very focal or generalized. And the kind of seizure you have depends upon what part of the brain it's in. So, for example, people with frontal lobe seizures can have bizarre behavior. People with temporal lobe seizures can experience things like deja vu or automatisms, where they do certain motions or movements. And then people with occipital lobe seizures will see things, because that's where vision occurs. So how your seizure presents depends upon where in the brain it's located. And seizures can even produce violent behavior and abnormal behavior. So it's very important to understand these things. Now, back to the workup. So it really is crucial for a proper history and physical. And this is an old school history and physical. You have to know your neuroanatomy, and you have to know how to do a complete and thorough bedside neurologic exam. Most physicians do not know how to do that. They do a minimal one. Only a neurologist really knows how to do this. I had 6 months of neurology. I learned how to do a pretty good neuro exam, more than what the average primary care doctor is. Let me tell you, there is a lot to doing a neuro exam, a good neuro exam. And I think any neurologists out there will be happy to hear me that I tip my hat to you guys and gals for the quality of the exam that you guys do. All right. So the evaluation involves a good exam, history and physical, laboratory evaluation, and then imaging. And MRI imaging with the seizure protocol is the best imaging. If there's concern about bleeding, obviously you would use a CAT scan. And then depending upon the kind of seizure and how it manifests and what the symptoms are and so forth, the physician can choose. There's a whole menu of medications that can be used. And the medication choice really depends upon the type and kind of seizure. For most general purposes, the three dominant medications today, and I'll use the brand names because the patients probably don't know the generic names, but and I hate to use brand names. It embarrasses me as a doctor to use brand names, but I'll use them on this exceptional case. Lamictal, Keppra, and valproate are it's kind of the mainstays. Back in the day when I was a student and so forth, we used Dilantin or diphenylhydantoin. In fact, the research that I did when I was in medical school was on how diphenylhydantoin works. And then there's the issue of, it's really requires really close follow-up and adjustment of the dosages to get these medications right. It's not at all unusual for people who are on various seizure medications to have difficulty controlling them. They're not easy to control. And it's an art form, knowing how much to give, what dose to give, a combination. Sometimes two anti-seizure medications need to be used. And doing this is really an art form that is really reserved for someone who has special expertise in the management of seizures. When I had my internal medicine practice, my brick and mortar practice, I would always refer seizure patients to a neurologist to fine tune their medications. It is a very, very nuanced and requires a gentle touch and a very good diagnostic understanding and therapeutic understanding on the part of the physician to manage them. There is an issue with breakthroughs or seizure or failure of seizure medications, and that is often due to noncompliance by the patient. Sometimes they just miss doses, and other things like alcohol consumption. So sorry, RFK, not everybody should be liberalizing their alcohol consumption. People with a history of seizures should not be drinking alcohol. You forgot to mention that, Bobby. And then there's other reasons why sometimes a seizure medication might not work and have to be changed. And then there are some people who have refractory epilepsy and medication doesn't work. And for them, there's a whole new world of invasive neurosurgical things that can be done to control seizures. And those are done at very high level of care, tertiary academic medical centers like the University of Southern California, Cedars-Sinai Medical Center, UCSF, Beth Israel Deaconess. These high level places are now using various implantable electrical things to control seizures in people who can't be controlled by medication. So all in all, seizures are very, very complicated, and it really is a very subtle area of medication that requires tremendous clinical knowledge and excellent management skills. So as a primary care physician, that's pretty much sums up, my level of understanding of seizures. I really like this idea of taking on topics that come from the audience. I'm happy to address any topic. I will always provide qualification of what my limits are on this, those areas where I am not a specialized expert. I'll give a general overview as I would as a internal medicine physician, while always deferring to the advanced expertise of the doctor who's trained in that specialty, which is what all doctors should do. If you are not an infectious disease doctor, stop pretending that you are and stop writing policy that affects the public. Defer to infectious disease doctors, just as I am deferring now to the neurologists out there in the room. So I hope that's of interest. And I'm happy to entertain any questions.
I want to talk about the related issue of, seizures and delirium in seniors. So I'm not a doctor. I'm working off of AI and personal experience. And AI tells us that the highest incidence of new cases of seizures occur in people over 60, and the rate of seizures in people of epilepsy in people over 80 is 3 times the rate in children. So your brain requires a lot of energy, and the older you get, the closer it gets to your body's ability to supply your brain with what it needs, the margins shrink, and it's easier for to send somebody into delirium. And a senior, it happened to my mom, it happened to my mother-in-law, it happened to her brother. And if uh, if your doctor isn't familiar with delirium in seniors, and I assume this also maybe extends to epilepsy, they can overlook stuff like a UTI, a cold medication can all tip somebody over into delirium. They start talking nonsense. They don't know where they are. The family, including us, from our experience, thinks, oh, this is it. This is the final stage of dementia. They've tipped over into, but often if you check somebody for a UTI, a senior, somebody who's 80, clear up the UTI, the delirium goes away. And I've got a real world example that affected all of us. Joe Biden, when he did the debate, he had a cold, and they probably gave him cold medicine, and his doctors probably weren't used to senior medicine, and he was all loopy for the debate, which changed politics.
So that's all very good points, Rick. Just a comment. We have to, lumping all these things together, delirium, seizures, and epilepsy is a little bit, you have to be careful there. And here's why. Delirium is an alteration in your level of consciousness that can be produced by a whole variety of causes, including low blood oxygen, drug intoxication, and so forth. Infection. It's not at all unusual for people, especially elderly people, to get delirious and confused and even semi-comatose and so forth with infections like a urinary tract infection. Yes, you're absolutely correct about that. And yes, when you get delirious, if you're delirious from drugs or delirious from hypoxia or delirious from an infection, that can provoke a seizure. That can give you a provoked seizure, like I referred to previously, and that's not in and of itself epilepsy. The diagnosis of epilepsy requires 2 or more seizures that are unprovoked, without a provoked cause. So if someone has a urinary tract infection and gets delirious and has a seizure, that's not epilepsy. That's a provoked seizure. Now, one more little, and this is just, now I'm going to just speculate a little bit based upon my experience. If an elderly person develops epilepsy, unprovoked seizures, at an advanced age, that really is a red flag. A clinician should really look hard for a structural lesion. In almost every instance of patients that I've had who've developed unprovoked epilepsy in elderly ages, they all had some sort of structural brain lesion. So those are all things that should be, there's some nuanced and things you need to parse out between those three. But you're absolutely right. Delirium is really common. You see delirious, just go to any emergency room. And I guarantee if you walk into an emergency room with 20 patients in there, at least 3 of them are going to have delirium for some reason. Most often it's intoxication that causes it, or infection. But people get delirious all the time from substance abuse and substance overuse and so forth.
I have a tip for avoiding some kinds of brain insults. As you get older, you want to work on balance, because falls kill old people and they cause brain insults because you bonk your head.
Yes, that is fall assessment is a really big part of geriatric medicine, and it's something that nurses are really good at this in the hospital. When a patient is admitted to the hospital, one of the first things, and it's partly because of federal requirements, they're obligated to do a very comprehensive risk of fall assessment, because patients fall all the time at home, in the hospital, and a fall in an elderly patient can be the end. The famous book, The House of God, that all doctors must read before they do their internship, talks, in tongue in cheek about hospital patients falling from the neurosurgical height or the orthopedic height, depends upon how high the gurney is, whether they have a neurosurgical fall or an orthopedic fall. And I don't mean to make light of this. These are very serious problems. And as you get older, preventing falls in the elderly is very critical. How many people die as a result of an injury sustained in a fall? The Kiss guitarist Ace Frehley just passed away after injuries sustained in a fall. Keeping lights on in their house. Do not get up in the dark. Elderly people sometimes get up in the middle of the night, they go to the bathroom in the dark, and they trip over something and fall and hit their head. My mother passed away at the age of nearly 93 after falling in her front yard and hitting her head. So falls in the elderly are a big deal. And you have to take precautions, especially if you're elderly, to avoid trips and falls. Get everything off the floor, pick your stuff up, and keep a nightlight on.
Also, as you get older, I'm in the fall range now. I cracked the bones in my wrist. I stepping off a curb. I went down, and like in the NBA, those guys fall. I don't understand it. Those guys, they fall from 7 feet high. But I'm not in the NBA, and so look where you have to change your habits. You have to start, like you said, keep things lit. Also, look where you're placing your feet.
Watch where you walk. How many
Walk
times
where
have
you
you
walk
heard
and
that?
everything like that. People say that all the time. You talk about the delirium and everything like that, and I think I haven't mentioned this in the show before, but I have one of my uncles and nephews, so he's actually on his side, not mine, but we still consider ourselves like cousins. He went through delirium recently, and the doctors have still been trying to figure it out and everything like that. Because I know my brother was actually his first call, and he was surprised that he was his first call because they don't really communicate a lot and everything like that. But he did know that he works in the field of dealing with at-risk youth and dealing with emergencies on a regular basis. So that in the back of his mind, he probably knew that he would be a good person to contact, even though my brother Malik was shocked that he contacted him because he wouldn't be his usual first point of reference and everything like that. But
Delirium, delirium presents typically in the emergency room. ER physicians are really good at evaluating causes of delirium. They see it first. They're kind of the primary care doctor for the delirious patient. Hospitalists, internal medicine, then the patient's delirious. The ER doctor kind of figures it out and then calls the hospitalist to admit the patient. And then it's the hospitalist physician, the internal medicine physician who's hospital based, who's really good at this also. And a lot of times then they will call in a neurologist to help clarify if it's a toxic metabolic encephalopathy causing delirium. I like the phrase toxic metabolic encephalopathy because it kind of gives you a little direction to go in your evaluation. You're looking for toxins and metabolic abnormalities producing the confusional state, which often clears. And I've seen this a million times, including in my own mom, who got a urinary tract infection that became encephalopathic and couldn't walk because of it. So these things are common as we get among elderly folks. But distinguishing between delirium, provoked seizures, and unprovoked seizures is really crucial.
Yeah, what advice would you give to people that are dealing with that situation? Because he also called me and was ranting and raving and talking about a lot of things that didn't make sense, including things that he wasn't even aware of because they happened before his birth and everything along those lines and everything like that. And what I did is I just gave him space to talk, and I think that's even what my brother did as well. And by the way, I think they're still trying to figure it out, even though this incident happened several weeks ago, the cause of the delirium, and he's actually still in hospital care and everything like that. Because originally we were thinking it might have been an early sign of early dementia or something along those lines that might be there, or Alzheimer's, but it is not that, because we think, he's about my age, so he's early 60s and everything like that.
You're making a great point there, Mark. As a patient ages, and it just gets back to what Rick was saying there. Your brain shrinks. You have fewer neurons, so your buffer is less. It's easier to get into trouble, and elderly people can become delirious. For example, there's a common medication used for sleep called Benadryl or diphenhydramine. Benadryl in an elderly person can really mess them up. They can be really confused for days after taking Benadryl, and you can get delirious from Benadryl. Working up delirium is a very deep workup, and you have to be a pretty skilled physician, usually hospital-based physician, to really know how to thoroughly evaluate and pick a cause. And sometimes even then you can't identify it, but it really requires a masterful internal medicine physician to figure out what caused the patient to get delirious if they had a transient episode of delirium.
So do people tend to, especially younger people, if they have a seizure, do they tend to hide it because an epilepsy diagnosis can really change your life? You're not allowed to operate a motor vehicle or heavy machinery?
Yes, and that's one of the reasons why some people are non-compliant. There's a stigma. Patients who have seizures of whatever type are often embarrassed. They don't want to talk about it. They don't want to admit it. Kids don't want to acknowledge, like being type 1 diabetic. They fight the diagnosis. They may not want to acknowledge it. They refuse to take the medications. They keep it a secret. They don't disclose it, and that can be a real problem because people are ashamed or embarrassed to have this diagnosis. It's a diagnosis just like any other, and people, they deserve to be cared for and helped. And there's a lot that can be done, but it requires that the patient, be forthright and take their medications. And yes, it can impact your driving. And a physician has the authority to contact DMV and at least temporarily restrict your driving privileges if they think you're unsafe. And they have to, actually. And usually to get your license back, it requires a period of 3 to 6 months or so, depending on the state, of being seizure free with documentation, confirmation from your physician that you're seizure free. But that's always a concern. And for people who have uncontrolled seizures or frequent seizures, there are certain things they just should not do. Climbing on a ladder and getting up 3 stories to work on your roof, probably not a good idea. Scuba diving, probably not a good idea.
Hey, just really quickly, and I know we're winding down, but how much do people ignore some of the symptoms of seizures? Because I know that you can have a sudden motion, or you can have other things, and you can have a bout of vertigo, and it might be a bout that you only have once every couple of years and everything like that, and people will ignore it because it is very scary, because I've even had that bout and everything like that, but you don't always because you don't know where you're at, and you're oftentimes in a spinning space and everything like that. But a lot of times it might be one that you have very rarely, because I think I had one episode, but that was like 4 years ago and everything like that. So it just was diagnosed as me moving too suddenly and not having a good diet, I think, at that particular time and everything like that. But I just wondered your take on these sudden incidences that can lead to possibly to seizures later on.
Well, there's a lot of different, there's a lot of complexity here, and there's a lot of different types of manifestations of seizures. There are things called absence seizures, or absence, as we used to call them, absence seizures, where you just tune out for a second. It happens in kids. They just zone out for 5 or 10 seconds. They're just not there. That's actually a type of seizure. And then there are twitches and things that, seizures can have a lot of presentations. Some people have crazy seizures where they are awake in the middle of the night and don't even have any awareness of it. Right. So there's a lot of complexity to this. This is really a very sophisticated area of medicine, and it's not an area for untrained people to be delving into this. That's why as a primary care doctor, if I had a patient with seizures, I always involved a neurologist just to be sure that they were getting the best care.
What about narcolepsy? My dad was said to have, he was probably just not getting enough sleep, but we considered it hilarious that you would just all of a sudden fall asleep in the middle of something.
Yes, I can. You're making me laugh because I can fall asleep anytime. My wife laughs because I can take a nap any place, anytime. 30 seconds, I'm out. Boom. On an airplane, I get on an airplane. I flew yesterday, and boom, I'm out in no time at all. My wife laughs about it. But yes, narcolepsy is a real thing, and even on The Sopranos, there was depicted. So, but narcolepsy that can require very specialized treatment. And there are doctors neurologists probably are the best at evaluating narcolepsy and treating it. It requires use of controlled substances to treat.
So it's not related to epilepsy. It's just one more way your brain can do a thing.
It's just, I'm sure there are probably some cases where there's some overlap between them, but no, it's a separate entity. Just like all of these things, narcolepsy, delirium, provoked seizures, unprovoked seizures, these are separate entities.
Mm-hmm. And with that, we're out of time, but we do want to thank Dr. Michael Patmos, who is board certified in internal medicine, who is discussing seizures, and thank our guest in the United States, around Virginia, who asked for this particular topic to be discussed. And we'll see you next week on Medicine and Science on the Pod TV network. Until then, stay safe and don't fall down.